Any other comments or questions before we dive into things? Okay, so a couple of jokes from the kids. What did one volcano say to the other? I lava you. Nice job. Okay, how about this one? What kind of dog do you find in a bakery? What's that? Hot dog? Pretty close. A purebred. All right, how about this one? Why do seahorses only like salt water? There are freshwater seahorses, but I didn't argue with my kids on this one. Why do seahorses only like salt water? Because pepper water makes you sneeze. Oh, come on, you gotta give them a little credit on that one. All right. So today we're talking about first renal diseases, and then next we'll talk about, after the break, we'll talk about liver diseases. And in true form that we've been talking about most of this semester, we're actually going to see and we're going to appreciate the way inflammation fits into this. All right, and at the break, if you haven't had a chance to pick up your Scantron, they're here alphabetized up at the front of the room. So just a couple of quick overviews for today. Whoops. Sorry. Let's pretend you didn't see that. The area of the kidneys that contain the glomeruli is where? All right, I already showed you the answer. So the cortex. My little clicker is really touchy today. All right, or it doesn't work. There it goes. So this is a review picture. Hopefully you guys all consider this to be a review. You can see a nice diagram of the kidney shown here on the right. We can appreciate the outer region is the cortex that we were talking about. And we've got this inner region known as the medulla. And the medulla is organized into these pyramid structures. And as things move through the tubular network, we're going to concentrate the urine, and eventually it's going to collect within the renal pelvis and empty from the ureter down into the bladder. Okay? So kidney function is quite important. Kidney function is quite important for filtration of the blood. So about 1/3 of all blood flow goes to the kidneys as it leaves the heart, comes off of the aorta into the renal arteries and perfuses into the right and left kidney. Now you can function with one kidney just fine. It has to work a little bit harder, but it filters the blood just fine on its own. But you cannot function very long without both kidneys and without dialysis. Okay, so patients that don't have kidney function that's appropriate are on dialysis. They'll usually do that a couple of times a week, usually about 3 times a week. In fact, if a patient goes off of dialysis and chooses to not receive filtration, they really will only last about 3 days before things will shut down, systems will shut down. So the kidney is a pretty important organ. We've got 2 of them because that's a backup system. Anytime you have something that's that critical and you provide a backup, it should give you a pretty good idea that it performs some very important physiological functions. Now we're going to talk today less about the organization of the kidney, but some of the structures and the function that you looked at in 202 is some of the background knowledge that I want you to be familiar with or be able to recall as we talk about different types of disorders, specifically looking at glomerular disorders, renal failure itself, as well as different types of infections. And infections of the kidney are real, but what's more common are infections of the urinary tract, or what we call urinary tract infections, UTIs. And those UTIs can actually migrate all the way to the level of the bladder, up the ureter, and into the kidney itself. And so it's something to be paying close attention to. The UTIs are actually quite common. A kidney infection is quite rare. the number of cases that move from a UTI to a kidney infection are few, because usually at the level of a UTI it's very uncomfortable, it's very painful, and the patient's going to go get seen. But we'll talk about how these things come about. Okay, as we continue on our review, just a different view of the kidney anatomy or the kidney architecture, keeping in mind that this renal artery and the renal vein pair come in right here at the collection of where the urine is going to flow out and down the ureter into the bladder. And so this is the renal artery that's coming in, giving blood flow or perfusion to be filtered. And then the filtrate moves down and becomes urine, and the filtered blood moves out through the renal vein. Okay? So on any given at rest cardiac output, about a third of your cardiac output goes through this filter. The other 2/3 actually bypasses it and goes and perfuses the rest of the tissue, providing it with nutrition. But you can kind of appreciate what's shown down here. The glomerulus is actually at the level of the cortex, and all of these tubular networks that kind of go back and forth, are part of that convoluted tubule system that functions using exchange of fluid and concentration, concentrates the urine eventually so that you preserve fluid, you reabsorb as much of the water as possible, and you're excreting your metabolites, you're excreting waste products, and you're minimizing the amount of fluid that you lose in the form of water. Okay, so that's our review. Pretty fast, kind of furious, but I want to get directly to the disorders. But before we do that, I want to go over some of these terms. These terms really should be review terms, but depending upon the type of 202 course you took, where you took it, or who your instructor was, you may not have had a lot of these clinical terms. So let's go over them briefly. So urea is a byproduct of two real things. We've got the catabolism, or the breakdown of amino acids, and we get a format of uric acid. We also have products in here that are the breakdown or the catabolism of nucleic acids. And the nucleic acids give rise to creatine. So we've got urea that's made up of uric acid and creatine as a result of amino acid as well as nucleic acid breakdown. Azotemia, the second term on this definition sheet. There's plenty of white space here for you to write some of this down. Azotemia is an elevation of creatine, and you see this in a number of different circumstances, including patients that are suffering from anorexia, patients that have hormonal levels, gonadal-hormonal levels that are very low, or we have patients that are suffering with fibrinous pericarditis. And high levels of creatine in the blood leads to another terminology, which is BUN, elevated BUN. This is blood urea nitrogen. So blood urea nitrogen is another product or waste product of protein metabolism that you're going to see in the blood. So if you have elevated blood urea nitrogen, BUN, that means there's a lot of amino acid breakdown or protein breakdown in the bloodstream. Eventually that's going to make it into the urine. Okay? Uremia, the third one on the list, uremia loosely describes illnesses or disorders around the kidney and around kidney failure. So uremia is sort of a general category of kidney disorder or kidney failure. Proteinuria, kind of obvious, but find what in urine? Protein, nicely done. Hematuria, what type of blood specifically? Red blood cells. Red blood cells in the urine. Pyuria are white blood cells in the urine. And you would see this on a urinalysis. You would actually get a urine sample from the patient. You would run to see what was in there, and you would see if there were high levels of creatine or uric acid. You would see if there were any evidence of red blood cells, which is hematuria, or white blood cells, which is pyuria, or if there's any protein. Oliguria is a decrease in urine production. And so if glomerular filtration rate, if you remember that terminology, GFR, decreases, then you're going to get a situation known as oliguria, diminished urine production. Okay, so different terminologies. We'll come back to some of them today. You might see some of them on your quizzes. There may be a definition on the exam, so on and so forth. Questions before we go on? Okay, well, we're going to dive right into renal diseases. And we're going to start out with our renal diseases looking at one of the most important functions or functional units, and that's glomerular diseases. So if we look at glomerular diseases, we've got a couple of different categories. And the categories are down here, but all of these diseases are disorders that modify glomerular function, and therefore they influence glomerular filtration. Many of them are immunological. We'll talk about that. So there's an immune issue, or there's antibodies being produced, or there's a hypersensitivity. These are all things that we've looked at in the past. In addition to that, as part of the immunology, we're going to see if things last or stick around chronically, we're going to see evidence of an inflammatory episode. Or we'll see the results of inflammation that was present. So we might see evidence of scarring in some of the chronic situations, and we'll talk about that. So some of the examples we're going to look at: glomerular nephritis, diabetic nephropathy. In diabetic nephropathy, we get a lot of accumulation of extracellular matrix. That's what the ECM stands for. And that shows up in the glomerular basement membrane. Now think about this for a second. If you get a thickening of the membrane of the glomerulus, so it's a thicker membrane now, do you think it's easier to filter, or is it harder to filter? Harder. Right? When you have a membrane and you're trying to filter across, you want it to be as thin as possible. So if you have a disease that causes thickening of that basement membrane, you will inevitably influence in a negative way urine production, or the ability for glomerular filtration to take place. And then we'll look at scarring of the nephron itself, or what we call nephrosclerosis. So first up with glomerular nephritis, let's talk about a couple of different situations. And let me orient you to this picture, because these pictures are straight out of your text, but they may not be all that intuitive. So this is really a picture of, we've got our basement membrane structure as it is in close proximity to our nephron, or our glomerulus. And so if we zoom in on this little box right here, that's what you're seeing across these pictures. And so this thick, reddish colored, like S, is our basement membrane. And this opening right here, as well as this opening right here, which are these three openings, these are all capillaries. And in the capillary network of the kidney, we've got these large fenestrae. Right, so this is a Latin term that means window. So if you see these little holes, these openings right here, the vasculature within the kidney is fenestrated vasculature, meaning it has these open holes. Why does that exist? This is 202, right? Do you guys remember the word fenestry? Fenestrated epithelium? Fenestrated endothelium, excuse me. What's that?
It sounds familiar.
Sounds familiar. Okay, that's the right answer. That was a very diplomatic answer, by the way. So, the fenestrated endothelium, having these large holes, makes it, do you think, leaky? Or do you think it makes it impermeable? Leaky. Why would you want to have leaky vasculature at the level of a filter? It's not a trick question. What?
To allow the plasma to get filtered out.
To allow the fluid to get filtered? If you had an impermeable layer, like at the blood-brain barrier, you wouldn't actually be filtering anything, right? It's not a trick question. This is totally a review. I was just kind of wondering if you guys were with me today. You guys seem a little zombie-ish. You guys a little zombie-ish? Okay, all right. You guys are thinking about that turkey already? Okay. So stick with me today, all right? We're going to cover some interesting stuff. You don't have to be present. I know you can watch the lectures online, so I'm glad that you guys came on a Thanksgiving week. But kind of track here. Maybe hold off on the daydreams of sugar plums and cherry cobbler for just a couple of more days, okay? Or maybe it's like pecan pie, and maybe it's mashed potatoes. How many of you, Mom makes the most amazing mashed potatoes? Okay? Do you guys like have little bits of skin or no skin? Are you like purists? Let's see, butter? I want those of you that are butter to raise your hand on your mashed potatoes. Okay? Those of you that are just no butter, just gravy, raise your hand. I think the butters have it actually. Let's see that one more time. Butter and then gravy. Yeah, it's definitely. Oh, did you put your hands up both times? Oh, I mean, it's America. You could do that. You could actually put butter and gravy on those mashed potatoes. That's awesome. Okay, so after you eat your Thanksgiving dinner and you drink to your heart's content, we're going to be filtering some of this fluid. Okay, we're back to the topic. You guys with me? All right. So we have holes in the endothelium of the kidney. And those holes are what we refer to as fenestrae. In the Latin, that means window. And that facilitates this filtration. This is a very important process. So that's what you're seeing down here. All of that background to tell you where we are in this figure. So here is the endothelium. Here's another piece of the endothelium down here. That's this one right here. And you can see the little holes on this side. You can't see them as well as you can see in the top three. But circulating through here is an antibody-antigen complex. Do you see that? So it's like a Y with an antigen on it. And that complex is floating through the bloodstream, and in this situation, when it's a circulating immune complex that forms, it gets embedded and it gets stuck in the filter. You guys remember this? This was back to hypersensitivities. So what kind of hypersensitivity would be a circulating type where the antigen and the antibody find each other, and then they get trapped, they get stuck in organs that get blood flow, like the kidney, like in joints, like in the blood vessels. You guys, is any of this becoming more familiar now? What's that? Who said it? Type 3. So we're bringing back a review concept that will absolutely rear itself on the flame. This is a type 3 hypersensitivity, which is this far left box, because you've got an antibody, right? We draw it as a Y, and we have an antigen complex that floats around these medium complexes, and they get trapped and lodged in areas that get blood flow. And the kidney is a big area. We talked about that a couple of weeks ago. We were talking about type 3 hypersensitivity, and now I'm bringing it back. So that's exactly correct. So over here on the far left, this is a type 3 hypersensitivity, and then we've got what we refer to as the category of circulating. This is a circulating pathogenesis. Well, we also have what we call in situ. In situ is a term that means in location. Okay? So in situ are these two examples. And in situ, you could actually, you see instead of the little complex, it's just a Y that's floating through the bloodstream. Now it's the antibody only, and it finds an antigen on the basement membrane and sticks to that. And that would be what type of hypersensitivity? It's not 3, it's 2. So now you have type 2, which is this middle one, in situ. Another version of a type 2. So the in situs are type 2. These middle and far right lower pictures are type 2 hypersensitivity. Here again, you've got just the antibody floating around, and then it finds some antigen that's within the glomerular network itself. And it also is going to bind there. That's a type 2 as well. The only reason this is a type 3 on the far lower left is because it's an antibody-antigen complex that filters through and gets trapped and gets stuck in the filter. So when we have these antibodies that are being generated, right, type 3 hypersensitivity or type 2 with in situ, they get trapped or they get lodged in the kidney. And then that triggers an inflammatory reaction towards that antibody-antigen complex. And so we get all of our classic inflammatory cascades that you've learned about all semester. So we get things like neutrophils being the first responder. Then we recruit these monocytes. They become future tissue macrophages. Right? Platelets arrive. They release all sorts of different cytokines. You recruit more inflammatory cells. You get dumping out of more cytokines. That's degranulation. You guys remember all this? And then eventually, you get the deposition of fibrin. You'll get the remodeling of the tissue. Right? And in some extreme circumstances, you might actually see some scarring that happens at the level of the kidney. All of this as a result of a type 2 or a type 3 hypersensitivity. So what does this look like if we were to use different types of techniques to stain? So I want to ask you this question. So we've got two different types of characteristics. All of this is under the category of glomerular nephritis. Right? So we're having an inflammatory event at the level of the glomerulus. Bless you. And you can't really see it on the left image. You can see it on the right image though. On the right image, you can kind of appreciate the capsule around the glomerulus. You guys remember that? And then you see this black space, this open space. That's Bowman's capsule. And so you can't really appreciate, there's a little faint hint of the capsule right here, down here in the lower right, on the left image. You guys see that? That little faint green line? So you can kind of appreciate that we're looking at the glomerulus. It's like a tuft of vessels surrounded by a capsule. Well, if you take a look over here on the far left edges, you can kind of see that these are punctate dots. This is immunohistochemistry, so this is an antibody that's fluorescently labeled, and then it binds to the antibody antigen that you've created it for. And so what we're seeing is we're seeing the result of where the antibody antigen reaction takes place in the glomerulus. And this one looks like dots or punctate. This one, do you see how it's more linear? It's smooth. So which one do you think is the type 3 hypersensitivity, which is the antigen-antibody complex that forms and gets trapped? And just to reiterate, that would be this one down here, where you see like a cluster here, a cluster here, a cluster there. And then which one of these do you think is the in situ version, where you've got a reaction of an antibody, a type 2 hypersensitivity, that binds to the basement membrane, and it's more of a smooth or a continuous stain? Any takers? Any guesses? Yes?
I think B is the smoother one, so it's going to be the type 2.
Which is referred to as in situ, or is it referred to as antigen-antibody complex that circulates? In situ. So B is in situ for all the right reasons that she just said. You guys catch all that? This one looks more smooth. So you've got likely an antibody that's binding to the basement membrane, and it binds along the entire surface of the basement membrane, giving you a smooth immunohistochemistry appearance using this fluorescent label. Over here on the left, this one's more punctate. There's like spots where the antigen-antibody complex is trapped. And this is because it's a type 3 hypersensitivity, and that type 3 hypersensitivity is where the antigen-antibody complex gets trapped as it circulates through the bloodstream, and it gets trapped in specific locations. And so it's not like a smooth interaction between the antigen-antibody complex is the complex that's circulating in the blood as a type 3 and gets stuck. Okay? So just to reiterate, perfect answer. This is an example of what you would see on a circulating antigen-antibody type 3 hypersensitivity, and the panel B on the right is what you would see with in situ. Now there were a couple of hands that went up. Questions? Or did I explain? Okay, I explained it. Okay, cool. So, moving away from glomerular nephritis, now we're looking at rapidly progressing glomerular nephritis. Okay, so it's just a slightly different version. Rapidly progressing, a lot of times this is idiopathic, meaning we don't really understand the causes of what happens. Rapidly progressing, as it would sound, is it comes on quickly and it moves through the different stages of the disease very quickly. It may be associated with post-infections. It may be associated with post-strep infections, or in some cases associated with systemic lupus erythematosus. Now, the left image is a normal glomerulus. So if I back up to the fluorescent images, instead of having sort of a green or a yellow architecture, here we're actually seeing the histology with light microscopy, not fluorescence microscopy. But you can still appreciate the Bowman's capsule around here and the space. This is a normal glomerulus. And over here, you can kind of appreciate the diseased, right? The diseased situation is we've got a lot of inflammatory cells, which are more purple dots that fill up Bowman's space. And so here's the glomerulus right here, here's another one right here, and the white glomerular space, which should be here, is actually filled with inflammatory mediators. So the glomeruli look as crescents, and so what you're looking at as far as a crescent shape is you're looking at the pink stain, which has sort of these crescent shapes of the glomeruli as they're becoming scarred. Okay, so they lose their sort of wire loop phenotype, and they become a lot more indicative of an inflammatory reaction that's taking place. So now what happens is we get a lot of leakage of proteins. We would see in these patients a tremendous amount of proteinuria, or protein in the urine, as a result of damage to the architecture at the level of the glomerulus. They become overly leaky. So a next version of glomerulonephritis is what we refer to as acute diffuse. Acute diffuse glomerulonephritis, these patients classically are younger. These patients are classically younger, between usually the ages of 6 to 10, although it can happen at any age, anybody in this room or anybody my age. Usually, though, in these acute diffuse, it's a infection, and it's post-infection, usually 7 to 28 days after an infection. Usually the infections might be staph, might be a pneumococcal infection, it could be viral. It also could be a strep infection that took place. And so these, in the case of strep, we get the antigen-antibody complex that forms, and then it gets trapped in the basement membrane, okay, type 3 hypersensitivity, and then it causes this inflammatory event to take place. So here we go. If we go backwards, one here, here's our normal glomerulus. Here's another view. You can see you've lost the Bowman space. We've got many more nuclei present, which are inflammatory mediators that are coming in. And we lose the architecture yet once again of the normal glomerular space because it's replaced with all of these inflammatory mediators, the neutrophils, the monocytes that turn into tissue macrophages. Okay, and if this is left untreated, then it's going to move on, instead of acute, it's going to move on to what we refer to as chronic. Now this is where it gets really bad. So if we look in the realm of glomerulonephritis, the early phases, the acutes, the rapidly progressing, all of these are manageable at some level. When we get to the stage of chronic glomerulonephritis, now we start seeing some permanent changes or permanent scarring that is non-reversible. And we're going to parallel this with the liver. After the break, we're going to come back and we're going to see some of the same type of examples histologically in the liver when we look at chronic liver disease or cirrhotic liver. Okay, so this would be, it's not really what it's called, but it would be cirrhotic kidney. But it's called chronic glomerulonephritis, where you get severe scarring. So this is a glomerulus. It doesn't look normal. Look at how much of a gap or how wide open the capsule is. But you see all these blue tufts that resemble about the same shape and size as this one that looks like it's about to die? What are those blue tufts or those blue smears?
Scar tissue.
That's scar tissue. What were they? What did they used to be? What's that? Glomeruli. Okay, so this is a glomerulus, this is a glomerulus. The plural form is glomeruli. So all of these blue circles, this is a trichrome, a Mason's or a Mason's trichrome that stains collagen a blue color. So you can appreciate there's a little bit of blue right here. You see the little bit of blue in the background? There's a little bit of blue around here. There's some blue around here. There's some blue down here. But look at this. This is all new collagen. And that's as a result of fibrosis. After the glomerulus died, okay, the tissue remodeled, and the tissue that was laid down in replacement of it was collagen, just like what happens on the skin. And so the scarring that happened at the level of the kidney is this wound healing response that's not a replacement of function, right? So it's not regeneration. What's the other word instead of regeneration? What is it? Resolution or repair. Okay? So you don't have return of function, but you actually have new tissue that's there. But this tissue that's there by this Mason's trichrome is showing you that it's new collagen that's deposited. And if it's aggressive, this is at autopsy, you would actually be able to feel, if you ran your hand over the surface of this, you would feel bumpy. Okay? And a normal kidney should be smooth. Maybe you didn't know that, but normal kidney should be smooth, okay? And this kidney would be bumpy, and that cobblestone sort of appearance is a result of that fibrosis, that chronic glomerulonephritis. And this is typically the most common cause of renal failure, is where you've lost such a large percent of the functional glomeruli in the kidney that now you don't have any functioning nephrons. Chronic glomerulonephritis. Okay, so if we have a patient that's suffering from glomerulonephritis, let's say that it's either rapidly progressing, let's say that maybe it's acute diffuse, but whatever type it began with, it's moved on to a chronic form. Now I want you to talk amongst yourselves. What are some of the clinical side effects that you might anticipate? Use some of the terms that we talked about earlier today. Okay? Okay, what do you guys think? Give me some ideas of what you would see at the level of the patient.
Oliguria.
What's that?
Oliguria.
Oliguria? Diminished urine production? Completely agree. What else?
Proteinuria.
Proteinuria. Protein in the urine? Completely agree. What else?
Edema.
Edema, where? In the body. Completely agree. Tissue edema. Right? If the kidney is not processing this fluid, it's going to go somewhere. Okay? So you're going to get a lot of tissue edema due to fluid retention. Anything else?
Increased blood pressure.
What's that?
Increased blood pressure.
An increased hypertension, an increase in blood pressure. So one of the best ways to control blood pressure quickly, right, to get it down, is you actually make the patient pee. Give them a diuretic. Okay, and that lowers blood volume and it actually lowers blood pressure. Okay, so we would expect these patients to be hypertensive. How about any blood? Would you anticipate any blood in the urine if you're getting protein? Protein's big. To get protein in the urine means that there's probably really large defects or holes in the vasculature. Would you anticipate to see some blood? Amount of urea? Absolutely. Okay? So I'm just trying to encourage you guys to, take what you've already learned, or maybe what we've reviewed, okay, and try to apply it now to a disease state. Because first, in order to understand pathology, you have to have a pretty good handle of how it normally works. Because the way it works is we figure out how does it normally work, we figure out what system is compromised, and then you can identify what the problems are going to look like. Or the opposite might be true. The patient presents, you know what the problems are, you have to work backwards to figure out, okay, what could be wrong that would cause this to be seen? And that's the kind of thinking that we're trying to stimulate. Okay, so let's move away from glomerular nephritis, and let's talk about nephrosclerosis. First, a question.
Yeah, I got one quick question about the filtration. So, because the membrane integrity is getting compromised, why doesn't that increase the rate of things getting filtered out? Increase the amount of fluid you're losing?
So that's a good question. The question is, since the integrity of the architecture is being compromised, why wouldn't more fluid actually leak out? Okay. So if you think back to 202, and you kind of go back to some of your notes, you can reconstruct what the proximal and what the distal convoluted tubule looks like, and you can see where the glomerulus fits, right? So it goes like glomerulus, and then you have the proximal convoluted tubule, and then way at the end you have your distal convoluted tubule, right? And as stuff flows in, it has to flow in at a certain rate, and it has to flow in at a certain pressure. And then it has to be shuttled through this loop system very, very specifically. And first you start pulling certain things off in one location, and then you start pulling off other things in another location. Does that make sense? So if you ruin that architecture, you disrupt all of the above. You disrupt your pressure gradients, you disrupt your flow, you disrupt your ability to set up concentration gradients to be able to pull certain solutes off and then to allow you to pull off water. So just because you get more fluid leaking in on the front end doesn't necessarily mean that you produce more urine at the distal convoluted tubule. Okay? So you need all that architecture in place. Otherwise, it would just be a straight tube. Right? It actually wouldn't even be that long. You wouldn't need it to be. But it needs to be a really long loop system in order to allow for those concentration gradients to take place. Okay? So it's a really good question, but what it brings up is the stuff that you learned about in renal physiology is critically important. And so when you compromise that architecture, then you start ending up with all these issues. Okay? All right, nephrosclerosis. So this is a scarring of the tubule, right? Sclerosis is a scarring. Now I'm going to kind of foreshadow or flash forward to 2 lectures from now when we get to cardiovascular, because we're going to look at atherosclerosis, right? Similar word, but we're talking about scarring inside of a blood vessel. So this week, we were doing some experiments in my lab. We actually really focused pretty heavily on 2 big areas. One is wound healing, as you guys know, and then the other one is vasculature. And so we're in the process of a really big project where we collect all these cadaver samples. And we get these cadaver samples from donor tissue, and we have all these really tight parameters that we put around what kind of blood vessels we want. But what we're trying to understand is we're trying to categorize sort of quote-unquote non-diseased but aged non-diseased. Right, so like an 80-year-old patient, the vessel that comes out is not going to flex like the vessels that come out of younger patients. So we call it non-disease, but it's aged non-disease. Then we have what we call mild disease, then we have what we call severely diseased. Okay? And if you look at down the tube of the severely diseased, you might see various different occlusions or sclerotic lesions. And some of these lesions are pretty aggressive. And we're going to talk more about this in 2 weeks. But I just want you to start thinking about it now. So this is sort of the normal, looking down the tube of a blood vessel. You might see something that kind of looks like this. And all of this stuff is disease. And this is the only blood flow that's in existence. And so this atherosclerotic lesion, which is very similar to nephrosclerosis, is a narrowing that takes place because we've got a buildup of disease. And we'll talk about that in the blood vessels in 2 weeks. But today, what we're talking about is we're talking about this nephron. So you can see up there, not too different than my drawing right here. Right? So what's up at the top here is, look at the thickening that's actually taking place in this tubule. This is all actually hyaline cartilage as it remodels. It should actually be a nice open, this white little slit should actually be a giant opening. It's actually closed down because of all this hyaline cartilage that's been deposited. We often see these in diabetic patients, and we see these in patients that suffer from severe hypertension. Because if you have high blood flow, or high blood pressure, that high blood pressure is going to be perceived at the level of the tubule network, and so its response is to remodel. So if you have chronic hypertension, you're going to get this nephrosclerosis that takes place, where the nephrons are going to say, okay, well, I'm going to thicken my wall because the faucet is turned up so high. So I need to have a thicker a thicker wall of this piping in order to handle the pressure that you're delivering. And so this is the remodeling event that takes place. Does that make sense? So if you get this new morphology of this hyaline cartilage, or this hyaline arteriosclerosis that takes place, do you think it's going to be easier or harder to filter? Why is it harder to filter? You're right. Why? I don't know. It just seemed like the right answer. You're kind of setting us up for harder. Why is it harder? You would have to ask that question.
Decreased flow.
Decreased flow? Do you think that the ability to fuse across a thicker membrane is easier or harder to diffuse across a thinner membrane? Harder. Okay? So you have less flow, you don't have as great of a pressure gradient, and then you have a thicker distance that you actually have to get across. Some of you are putting on jackets because you're cold, right? So what you're trying to do is you're trying to create a thicker insulation so that the cold can't move across that membrane of your skin, right? So here, if you want to encourage things to move across, then you thin that out. So in nephrosclerosis, that thickening of that wall is a problem. A very, very big problem.
Is that reversible?
Not at this stage. In the early phases it is, but not at this stage. This is a pretty severe example. You're kind of stuck. Now all of the nephrons in the kidney won't look like that. So it depends upon when you catch the disease, you may actually have some ability to intervene. Okay, so what are some of the clinical symptoms associated with nephrosclerosis? Well, we're going to get proteinuria. We're going to get generalized and focal ischemia of the kidneys. because now blood flow is compromised. It's not just, as we look at this picture, it's not just these nephrons. We actually get hyaline arteriosclerosis happening in the blood vessels too. And so that compromises blood flow. And then we get a decrease in serum protein. A decrease in serum protein. So our last category, we had glomerular nephritis, then we talked about nephrosclerosis, and now we need to talk about renal failure. Okay, the last little segment of kidney. So, acute renal failure, as the word would imply, this is kind of, early on. We've got a rapid, severe decline in function. We decrease our urine production. And we've got really 3 ways that we can decrease or see a reduction in glomerular filtration rate. Number 1 is it could be something that happens before it actually makes it to the kidneys. So the example would be shock. If the patient's losing a tremendous amount of blood volume, number 1. So pre-renal or before it actually gets to the kidneys. We can have something happen at the level of the parenchymal tissue, or which is a fancy word that means the functional tissue of the kidney. So if it's parenchymal, this would be things like glomerular nephritis or acute tubular necrosis. Or lastly, it could be something after it leaves the kidney, like post-renal. It could be a urinary tract obstruction. Okay? So in these categories, acute renal failure, we've got these 3 possible categories. Number 1, infection. Right? We're going to look at pyelonephritis, which is a type of infection that we're going to talk about here in just a minute. Secondly, we could see it being acute tubular necrosis. Now, this happens to be one of the most common causes of renal failure. And if you remember again back to 202, when you looked at renal physiology, the nephron itself, the nephron tubules, are really the last structure in the kidney that actually gets perfused blood flow. So they're the last ones to get oxygen. That also means they're the first ones, or the ones that are most susceptible to ischemia. So if you have decrease in blood flow to the kidney, or if you have an infarction that's taking place because you have a blockage at the level of the renal artery, then the nephrons are going to starve. And if the nephrons starve, we get ischemia. And the ischemia leads to tubular cell injury. This tubular cell injury is either reversible or it's non-reversible. If it's reversible, you're going to go through some tubular glomerular feedback. Eventually, you'll kind of reduce glomerular filtration. You'll correct it on the next cycle, come back, and it'll be fine. But if it's non-reversible, then you either have necrosis or apoptosis. You know what those 2 terms are now. And if it's necrosis, then we get an infarct. If we get an infarct and it's necrotic tissue in the kidney, it would be what type of necrosis? Coagulative, right? Kidney, heart, spleen, all of these are types of organs that are subject to coagulative necrosis, but it's also because they have a very organized branching network of vasculature. And so when you lose a branch, you get sort of a wedge-shaped scar that takes place. All right? So ischemia. The other one that could cause this is ischemic independent, is toxins. There are various types of toxins that are poisonous, if you will, to the kidney. So a classic one is radiopaque contrast agent. Okay, does anybody know what that is? Hopefully none of you had it for breakfast, right? So radiopaque contrast agent. So if you're in a clinical setting and patients are actually getting imaging, okay, so they're having a CT, or they're having an angiogram, or they're under a procedure which is using X-ray technology to visualize what's happening, and we usually call it under fluoroscopic guidance, they will inject contrast agent into the patient. The contrast agent is usually like a barium sulfate. And that contrast agent collects in the kidney, and it's actually a renal toxin. And so they're always monitoring how much contrast they deliver to a patient, because you don't want to actually kill the kidneys. Okay? We're going to look at another toxin to the liver after the break, and that one you're probably much more familiar with because it's more popular in the newspaper. Okay? And that's alcohol. Alcohol is a hepatotoxin or a liver toxin. And so we'll talk about that one. But contrast agents are toxic to the kidneys, and that's why when you're under imaging, you're always trying to pay attention to how much contrast you're giving the patient. Because you might actually, save the brain, treat the heart, but then the patient comes out and they're in renal failure because you gave too much contrast agent. So there are other examples of toxins that will cause damage directly to the kidney. The critical events, injury to the tubules, and then any sort of blood flow disturbance that's going to take place. Okay, and then really the third mechanism, or the third category that can cause acute renal failure is shock. So in the example of shock, we see that if the patient has trauma, that you decrease the blood flow. Instead of a third of blood flow or cardiac output going to the kidneys, you actually get none. And this is going to ultimately lead to a decrease in urine production. Okay, it kills the kidney. So what's shock, just to remind everybody, right? So this is severe reduced delivery of blood to tissues. So this might happen in a traumatic transection of the aorta. It could happen in a car accident where you've got internal bleeding or internal hemorrhaging that's taking place. It may not be blood that's actually coming outside of the body. It may be internal bleeding that takes place that actually is causing these sorts of problems. Okay, the last little component that I want to talk about is infection. Okay, so now we're talking about when the kidney itself can actually be subject to different types of infectious agents. And of course, very high up on the list and very, very common are what we refer to as urinary tract infections, or UTIs. Second up, and I mentioned that we were going to talk about this here very shortly, pyelonephritis. Pyelonephritis is a type of ascending UTI, or urinary tract infection, that actually moves up from the urethra and can contaminate or infect the bladder. And then it can move up from the bladder to the ureters. And as it moves up the ureters, it actually can eventually hit the kidneys. And you say, well, golly, wouldn't you know that was happening? Well, yes, maybe. Okay. In some cases, it may not be immediately treatable. Okay. In certain countries, that's not the case, where we have this kind of access that we enjoy in our country to medical care. So pyelonephritis can either be acute or chronic, and utilizes what we call this reflux nephropathy. So in all of us, there is a little bit of a reflux after urine flow stops. There's a little bit of a reflux in a retrograde fashion. Okay? And that reflux in some patients is exaggerated. Okay, just like you would expect. Biology is very diverse. Okay, and in some patients this reflux is actually more pronounced. And what we refer to it as is this vesico-ureteral reflux. So VUR, vesico-ureteral reflux. And this encourages or allows or facilitates a retrograde activity that can move different types of elements, including bacteria, sort of backwards. Okay, so we'll talk about that just a little bit more here in just a second. But overall, there's two main routes of infecting the kidney. One is the one that we've been talking about, which is a lot more common, and that's a retrograde, or what we call an ascending infection. The other one is a descending infection, or what is bloodborne. So hematogeneous means that the bacteremia is in the bloodstream. And so if a patient becomes systemically infected in their blood, because a large portion of that blood goes to the kidneys and be filtered, then that bacteria is going to get trapped in the kidneys. And so if you have a descending infection, common agents are going to be like staph and E. coli that might be in the blood, and they're going to, in a sort of anterior grade or a descending or a blood-borne pathway, make it into the kidney. But what's a lot more common are infectious agents coming in a retrograde, not an anterior grade, but a reverse direction or an ascending direction. A lot of these common agents are different types of bacteria, like E. coli and others. And this pyelonephritis is one of the most common ways this takes place. Okay? So pyelonephritis, again, this is a urinary tract infection that ascends. It's more common in women because the urethra in women is a lot smaller than it is in males. In addition to that, prostate fluid in males has an antibacterial property to it. So it actually helps to kind of keep the urethra clean, the prostatic fluid. The problem in this vesico-ureteral reflux, or this VUR, again, so gender, females are more susceptible. Some patients have a larger VUR than others. Urinary tract obstruction will accelerate or pronounce or increase the chances of developing a urinary tract infection because you're not flushing things out as quickly as you normally would. And then there could be congenital abnormalities that take place here. And some believe that an exaggerated VUR could be one of these congenital abnormalities in some patients where there's more of a recoil of the fluid as it moves up. So the problem is, it'll move up and it'll hit the renal pelvis, target the functional tissue of the kidney, eventually even make it to the renal calyces. So this reflux nephropathy is a form or a subset of chronic pyelonephritis associated with continuous UTIs and a VUR reflux that's very aggressive. And in extreme circumstances, you can actually start leading to scarring or damage of the kidneys themselves and compromise urine production. Okay? Questions? Okay, so just in summary, on the kidneys, we talked about an overview. I think, judging by the temperature of the room, I think it might be wise to dust off some of the renal phys and renal anatomy lectures that you had in 202. Because if you don't really have a good foundation on that, it's hard to understand where are all these problems and why are they existing. We talked about glomerular disorders, we talked about renal failure, and we talked about infections. Okay? Let's take a break and then we'll finish up with with liver.